done. Very good. Dr. Z?
The sooner I finish, the sooner everyone can get out of here, I guess. Okay. Just want to take one quick moment. So I figured, as some of you know, there's been a lot of changes going on at TLC, and yesterday you met our new CEO, Steve Takis. I also want to introduce our new medical director, Chris Falco. Chris is a PM&R doc physiatrist. He predominantly works at Tier Hospital. He comes to us Tuesdays and Fridays, and he's been with us now for just about a year, right? April of last year. So he's been a valuable member to the team. We love working with him. He's really hands-on, and we're really excited. So I just wanted to make sure that you guys got a chance to meet with him, being that so that everyone's aware of some of these changes that are going on, all positive changes. So, all right.
Nice to meet you all.
Okay. Thanks, Chris. I appreciate it.
Last session, guys. When we finish with this session, we will have the performance or the program evaluation. Will you please complete that? And then we have the forms for the LPC. Yes, we have a CDE and CRC forms and LPC. Guys. Very good. Okay, we're good to go. Very good. We all know him as Dr. Z. Dr. Z, can you help us with the last name?
Oh, it's been how many years now? Come on, Bill.
I know.
This is Galjardic. This is Galjardic.
Galjardic.
You do say the Z. You do. This is Galjardic. Say the word scallion. Say it's Galjardic.
Galjardic.
You got it.
Got it. All right, man.
My wife's a trained teacher, so she kept using that with the children, and they picked it up right away. So the scallion works.
All right. Very good. Dr. Galjardic.
See? Every time.
Very good. Dr. Galjardic is the Clinical Program Director here at the Transitional Learning Center and also Assistant Professor in the Departments of Rehabilitation Sciences and Neurology at University of Texas Medical Branch, which is just next door. Dr. Galjardic, thank you very much.
Oh, you're very welcome. Very welcome.
Dr. Galjardic is going to talk to us a little bit about post-acute brain injury rehabilitation. Thanks, Dr.
No, you're very welcome. Thank you. All right. Folks, I left some business cards this morning when you came to your tables. I don't think I had enough, so if you want more, I'll just leave them up here. You guys can grab them, okay? So this is I've presented at this conference several times before in the past. I've had different topics. So again, if this is a topic that I did present to you before, I apologize. I'll try to make it a little bit more interesting before, given it's a Friday afternoon. I know I don't want people to start falling asleep on me. And again, thank you so much for coming. And TLC is just delighted to have you guys here come almost each year. And like I said, as we move up the road, we will keep Bill informed. And once we are up there, we'll be more than happy to accommodate you guys again for this conference. Okay? We appreciate you coming. All right. So as Bill said, I'm a neuropsychologist, and I've been here now at TLC since 2005. Been here for just about 13 years. And up until this last year, I'm still the neuropsychologist. I still act as a neuropsychologist, but this year has been mostly administrative work. But still, having worked here all these years as a neuropsychologist, I'm going to talk to you today about the strategies that we use in helping our folks, especially who have cognitive type impairments after their acquired brain injuries. All right, so I'm going to just go over some initial stats. These are things I'm sure all of you are familiar with. I'm just going to breeze through some of these and then get into some of the other stuff. So again, there's no doubt that TBI, and I'll say TBI sometimes, but I'm also going to be talking about acquired brain injury, which includes stroke as well as TBI. So it afflicts about 1.5 million Americans a year, occurs very frequently, just every half a minute or so an injury does occur. Thousands of deaths occur each year. About 1 million people are treated in emergency rooms. About 250,000 are hospitalized. And again, it is among the leading killers and disablers of young adults under the age of 35. And of course, we could all think about why that age range, but I think because of the nature of the accidents, and I have some factors up here that may explain that in just a bit. But again, when you compare it to some of the other types of chronic illness or disease processes that we do experience in this country, TBIs are it's a huge, huge issue. And as you can imagine, with the level of care that's needed for these folks also draws a level of cost. So we know that that's going to be an issue. And unlike some of these other situations, and not mentioning some of these, but like multiple sclerosis, spinal cord injuries, these are going to be chronic issues just as well as TBI. But as we do know, folks with TBI can benefit. We've seen it as rehabilitation counselors, as neuropsychologists. we know these folks can get better. So rehab is key. The incident causes, so again, why this age range? Why is that so important? I'll get to that in a moment. I'm sorry? Yeah, exactly. Well, yeah, that's part. You'll see a picture in just a second how fearless someone can be. So again, these folks can develop chronic disabilities, physical, cognitive, and psychological. So it's also very important to keep those in mind. Because when you see someone that may be injured after a brain injury, and they may have a physical injury, that can very well be an associated cognitive or psychological component to it. So keep that in mind. You may not be able to see it, but it could be there. And again, a large number of folks will live with disabilities with TBI in this country. So here are just some of the factors, or not factors, but actually some of the actual causes. So again, a lot of our folks, we do have motor vehicle accidents, is a huge percentage, falls, struck by or some sort of blunt force trauma, assaults, including that. And then we do have we have had some folks here at TLC that include in some of those other areas suicide attempts and other issues that can relate, associate with a TBI or acquired brain injury. Risk factors, doesn't mean that this causes a TBI, but these are in terms of cause, they are correlation. So males typically are more prone to TBIs than females. Issues with substance abuse is a huge factor. Learning disabilities, again, sometimes if a person is not being treated for a learning disability from a young age, that may lead to a certain path or trajectory that may lead them to engage in some other issues that could lead to a TBI. Psychiatric factors, prior history of brain injury or acquired brain injury like a stroke, medical conditions, or to sort of address Betty's question or query, not being too bright, okay? Making really bad choices. Yeah, so this does happen. We've heard stories. I mean, again, all of you that have worked in rehab, you've heard the stories. I'm sure we could chat here for hours about some of the stories we've heard. So with regard to acquired brain injury, this is where I'll sort of talk about the two in sync. With TBIs, we can look at it sort of acceleration or deceleration type injuries, motor vehicle accident, assault. Then, of course, in the case of a stroke, it's a location or a bleed on the brain, an infarct of sorts in the cortex. Other types that we do see as well, infection, sort of encephalitis type injuries where there's an infection of the brain. Tumors, of course. Sometimes the tumors give us an indication of some of the issues that may come, but usually when there's a tumor resection, sometimes cortex comes out with the tumor, and that can also cause a lot of difficulties for the patient. And then, of course, anoxic or hypoxic type injury. So if an individual does experience some sort of cardiac arrest and there's a huge deprivation of oxygen to the brain for a prolonged period of time, usually in these cases, person will experience severe memory deficits, sometimes also executive type dysfunction as a result. But here you typically won't see the damage on a CT or MRI, but through clinical evaluation, you'll clearly be able to realize that something did happen. Okay. So also I'd like to talk about two different types of injuries. We have our closed head injury, and of course in a moment I'll talk about open head injuries. But with the closed head injuries, there's no skull fracture, and typically it's more of a CVA or a infarct type event. Usually the person may experience a contusion or what we also call axonal shearing. So if you are a driver or passenger in a vehicle and there's an accident and your head does hit the dashboard, or even if there's a whiplash type injury, even though the skull is not fractured, doesn't mean you can't experience an injury. So what happens in these cases, unfortunately, the bottom of your skull is not a very forgiving surface, so your brain can actually move within the CSF fluid, the cerebral spinal fluid within your brain, and a lot of times the bottom of the brain can actually rub up inside the skull and cause levels of damage. A lot of times in my interviews, I'll ask patients, do they experience a loss of smell or taste after their injury? And sometimes they'll look at me a little funny, and they'll say, yeah, actually, yeah, I'm not, my appetite's really down the toilet, and food's not as appetizing to me anymore. In those cases, what happens is that the olfactory bulbs that are sort of right above your eyeballs, in those types of injuries, acceleration, deceleration, that bottom of the brain where the olfactory bulbs are will rub up against the skull and they could tear. So all of a sudden, an individual can have now an anosmia, which is sort of a lack of smell. And you can imagine if you have a nice, beautiful steak in front of you that's cooked well and so on, but you can't smell it, well, it's not going to be as appetizing. And of course, smell and taste are very in sync and associated. So really, the person could start losing appetite. So these are some factors that we could look at when it comes to the nature of the injury, okay? But also then you have to think about it too, all the neurons in our brain are covered in a myelin sheath. So think about the electrical wires that are in the walls here. You have a copper wire that's covered by a plastic covering, insulation. Now the reason that's there is of course to prevent any kind of fires, but also helps propagate the electrical information down the copper wire. Same thing with your brain. So you have this myelin sort of insulation around the neuron. In a shear injury, which is why it's called a shear injury, the myelin sheath shears off the neuron, and now all of a sudden the neuron is working, so in some cases, but the information is not propagated efficiently. So now information could leak out, and you'll usually, with more of a shear injury, people have problems with processing speed. They may be able to get to an answer, but it may take them a lot longer. Sometimes if they're processing information starts to fall out. They may say, oh, my memory's horrible, I can't remember anything. And that may be the case, but it's not because they have a memory problem. It's because the speed at which they manipulate the information is not efficient enough, and the information sort of falls out and they lose it. Okay. Then, of course, in addition to that, one of the biggest issues with a closed head injury is hydrocephalus. Okay, so it could be related to an increase in the blood or CSF collection after an injury. So in a closed head injury, if someone has a bleed, let's say they have a hemorrhage, what the biggest issue for them really is not always just the stroke itself, but the fact that now this blood product is starting to build up, and there's no other place for the blood to go. If the skull is not penetrated, pressure is still very large inside the skull. So what happens is the blood product starts to push down on the brain itself, not the skull, of course. The skull is very static. And what that does is the person, usually with the stroke, they'll be conscious in the beginning, and then sometimes after a few minutes or so, they start to lose consciousness because the pressure is building up so much and it's pushing down on the brain. Once it hits those brainstem structures, the person loses consciousness, okay? And usually what happens is the most damage occurs, not to blame the EMS, but by the time they get there, if a lot of pressure has taken place, it causes more damage, okay? And then, of course, in the open head injury situation, the skull is actually fractured. So as you can imagine, if the skull is fractured, it sounds much more horrible and horrific, but pressure is actually relieved in a lot of cases. So in some cases, the folks here have a better prognosis in some cases because that pressure is relieved, okay? So here's just a cartoon to show a little bit of the different types of injuries. So the focal injury, this would be more of a stroke. So imagine someone who's aphasic, right? They have a poor ability to speak. The right arm is probably hemiparetic because language is dominant in the left hemisphere, so that'd be more of a stroke situation. Polar injury, this could be more of your whiplash situation, which I mentioned, like the shear injury or the rubbing up of the olfactory bulbs on the bottom of where the eyeballs would be. Diffuse axonal, this is more of your shear injury, again, just a general torsion of the brain where the myelin sheath is being torn off. And then the last one here in the lower right is a secondary anoxic or hypoxic injury where there's a deprivation of oxygen to the brain. Okay, so for a prolonged period of time, this is cardiac arrest, drowning victims, and so on. Okay. Any questions so far? But just some of the basic TBI 101 so far? No. Okay. And then when it comes to, I know concussion is discussed a lot. You hear that a lot these days with the sports injuries and so on. But really, in some sense, this could be sort of related to more moderate or severe TBI. So in this case, when there's some sort of a bruising on the brain, which is what a concussion is, there's a sort of whole cascade of events going on. So at the moment of impact, you have an increase in the demand for glucose, which is the energy for all of us, for our brains. You have a decrease in blood flow. Well, now if the blood flow is down, the glucose can't get to those parts of the brain. And then, of course, there's a decrease in oxygen metabolism as well. So after a mild head injury or concussion, usually after about 4 to 5 days, a lot of the person's symptoms have resolved, and usually they could start to regain some of the usual skills and responsibilities. But it's usually those first few days where the coach hopefully will say, maybe it's time for you to sit it out, not go right back into the field to play. Whether it's years ago, I got rear-ended in my car, and I felt a little woozy for just a little while, but I just rested at home that night, and within a day or so, I felt like my old self again. But again, usually most folks within about a week or so after a mild injury, they do pretty well. Then, of course, there's a whole other, which is another whole talk I give about post-concussive syndrome and some of the psychological factors that can be impacted even with a mild injury, where those sort of drive a lot of the cognitive and other issues or symptoms related to the injury. So here's sort of a ugly picture of a slice of someone's brain after they experience a very severe middle cerebral artery stroke. And this is all the necrotic tissue. Again, this is obviously probably years post-mortem, but the point being here is that all that tissue, because of the lack of oxygen and blood product, or blood, all that necrotic tissue formed, okay? And then another topic that's sort of been debated for years within the brain injury world is how do we determine severity? We always hear about mild, moderate, severe injuries, but really how do we gauge that? And it's not very easy. I mean, it's simple math, but it's not really easy to do that, to really discern. So in the basic cases, we look at loss of consciousness. Well, if it's a mild injury, if you're less than 30 minutes, that's mild. If it's a moderate severe, it's greater than 30 minutes. And of course, in the most severe case, comatose, where you could have a loss of consciousness for more than 30 minutes. But as you could probably imagine, even someone who may have been 29 minutes unconscious, that could still very well be a moderate severe injury. So this metric I really don't focus much on. And again, if you think about the folks with acquired brain injury, if a stroke does take place, if there is no major amount of blood product, then the pressure is not severe enough, the person will most likely not lose consciousness. But it doesn't mean that their injury itself may not be moderate or severe, depending upon the lack or the loss of function that they may experience. So again, not the best metric. The metric that I'm more comfortable with when it comes to grading TBIs is post-traumatic amnesia. In this case, this is the amount of time it takes for an individual to be able to lay down new memories after their injury. So usually in the initial stages after a TBI, a person may have decreased mental status, they may be very confused, not oriented, maybe not even familiar with, or be able to name familiar faces, people. I've seen patients who really couldn't recognize their own parents or whatnot. And when the amount of post-traumatic amnesia is about less than an hour, usually the person can be deemed more as a mild injury. They'll probably recover much more quickly, not have a lot of significant cognitive or physical sequelae. Then once you start hitting closer to about 24 hours, that may now be on the cusp of more of a moderate TBI. Then, of course, in a case where this is greater than 24 hours, more of a severe case. And here at TLC, I've seen folks that have been months, if not a year out, of a prolonged PTA, and of course their chances of huge amounts of improvement are probably much lower than usual. Okay, and then the Glasgow Coma Scale, again, this is, I'm sure everyone's very familiar with. Really, this is the scale that the EMS in the field sort of ascertain. Again, most of the folks here at TLC have been more severe, 8 or less. This middle range and moderate range, I've never really paid much attention to, because really, I've seen some severe folks that had a 9 or 10. I've seen some mild folks that had a 9 or 10 in terms of their function. So again, another metric that I don't put too much credit in. I just sort of, I like to look at the actual symptoms. That's how I sort of gauge the severity, to be honest with you. And that's the coma scale there. So switching over now, now that I sort of gave the acquired brain injury 101, I want to go into some of the stuff that we do here, but more specifically with the cognitive rehabilitation. So before I get into that, are there any other questions about what I just discussed a little while ago? Yes, sir. Mm-hmm. So that's PTA, post-traumatic amnesia. So if now the person can have a retroactive amnesia where they're not remembering. So essentially, if this is point at which the injury occurred, there's usually going to be a certain level of a period of time before the injury and after the injury that the person's just not going to remember. Right, okay? That does not gauge post-traumatic amnesia. The post-traumatic amnesia is now, once new information is introduced to the person, today is, Friday, April 13th, 2018, but the person's still saying, oh, no, it's March of 1997, but you then reintroduce the information. Now, the longer it takes them to lay down that new information, that's the length of PTA. And they still may have some retrograde amnesia, but really PTA is gauged upon going forward, what new stuff they can learn. Okay? Any other questions? Okay. So with regards to cog rehab, it's a systematic, functionally oriented service of therapeutic activities intended to improve cognitive functioning through, we want to reestablish previous learned patterns of behavior. Now, everyone learns on their own ways, and again, I think maybe one of the, I don't want to say downfalls, but one of the things about cog rehab is it is a structured way of trying to help that person relearn. It may not have been that person's style beforehand, and sometimes if the patient is able to give us their feedback and say, you know what, I was really good with my phone. I was able to use the calendar on my phone. That's the way I help myself remember them. So the speech paths here will try to adapt that in their cog rehab. If the person was like, well, I'm more old school, I like the old planner system to write stuff down, we'll try to adapt that to them, okay? But what we try to do is try to make it as uniform as possible so we can use that same strategy across all patients as best as possible. We want to try to establish new patterns of cog activity through compensatory strategies. So, you know, before an injury, a person may be able to get from point A to point B pretty easily, or at least the way they've adapted over the years. And these days, through range of rehab, to get to A to B is not as easy. You may have to sort of take a few shortcuts or long cuts to eventually get to B. So that's really the goal. How do we get from point A to point B? And we have to now develop new ways to help that person do so. That person may be aphasic, person may now have may have visual spatial deficits. So how do we help them get their memory and other problem-solving skills back with modifications and support? And then, of course, establish new patterns of activity through external compensatory mechanisms and environmental support. So there's also the whole theory of, you know, loci or learning things spatially or verbally, depending on the person's impairment. And then enabling that person to adapt their cognitive ability in order to improve their overall level of functioning and quality of life. So really, what's more important for them? You know, sometimes we have folks in our ADL kitchen, and we're having them try to learn how to make a sandwich or do a basic meal, mac and cheese. And a lot of the time, it's usually the men. They're like, well, I don't cook. I don't need to learn this. But they're not getting is like we're trying to help them learn how to sequence and remember things in a safe environment. Because a lot of times these folks may go home and need to be home for a few hours by themselves. And the fact that they may be able to make a cold or hot meal prep on their own is important, whether or not they used to cook or not before the injury, okay? But again, it's a lot about sequencing and memorization. So we have to make sure that those skills get adapted into their environments at home, okay? So really, you know, cog rehab is really just another way to how do we replace an old system with a new system because there is now a dysfunction. It may take more time, not be as efficient as the original way that was done. However, the outcome should try to be the same. That's the goal. So again, rather than going straight point A to point B, you're sort of working your way around, but the goal is to get that final point. So this is not too far from what some of the stuff we've actually done here. So, you know, in the cartoon here, it says, you know, first pants, then your shoes. So our OTs will literally put these types of messages on the patient's board to let them know, okay, do this first and this first and this first, to really help them sequence, because we know that practice does make perfect in rehabilitation, or at least close to perfect as possible. So really get them in a routine. And the goal is once that person can start doing those things without those strategies, we take those strategies away. We're not going to leave them there if they really don't need them anymore. We want to sort of a stepwise fashion. So the goal is really to assess the limitations of learning, and a lot of times in the evaluations we do here, me being a neuropsychologist, my gold standard is the neuropsych evaluation to assess the cog and the psych domains. I want to make sure that I'm assessing that as well. But also within my neuropsych eval, I do sensory motor evaluation as well. So I really want to get a full picture of what are the strengths and weaknesses for that individual. I may not be doing as in-depth a motor evaluation as a PT or OT would do, but I'm trying to get some of the basic sensory and motor aspects of that person, especially with the fine motor skills. Try to develop proficient and reliable compensatory strategies based upon what our evaluations told us, and then again, of course, try to encourage some self-monitoring in real-life events. And that's really important, especially with our folks who have more executive dysfunction, where a lot of those folks, they may know how to do certain things, and they really, if you saw them on the street, you would think, oh, there doesn't seem to be any problems with them. But those folks may have some sequencing problems, other problems that they're not aware of that they're doing wrong. So really self-monitoring sometimes could be much more difficult to rehabilitate than a memory problem, okay? So I'll get more into that when I discuss executive functions in depth. So, you know, when I started, when I was training to be a doctor back years ago, a lot of the places I started to go to that were initially doing rehab, they were doing a lot of computer-based training. And at the time, I thought, well, this must be the way it is, but it's really not the way it should be. I mean, rehab should be done hands-on by therapists. We definitely should adopt technology. But in some of the early places I was in, of course not TLC, they were just sticking folks in front of a computer and they were doing tasks, whatever computer game it was, but you were really just training that person to that task. It doesn't generalize. So we got to be really careful as rehabilitation specialists that while the technology is great, iPads, all these other things that we're looking at, we have to make sure it does generalize to actual function, that we're not just teaching someone how to play a computer game, but we're teaching them how to then generalize that to something else broader in their environment. Okay, so when just looking at some of the levels, the way we look and approach rehab, the assessment level, of course. So we have a comprehensive team here, neuropsychology, speech path, PT, OTs. We, just this past year, we brought back a rec therapist. We didn't have rec therapy for about 5 years. So we did just hire one on. Again, we're excited about that. So all those folks will do all their evaluations, including Dr. Falco, who you saw. He'll do his history and physical as well to make sure the medical issues. And then once that all those assessments are done, the team meets. We all get a consensus on what we feel the strengths and weaknesses are. Then we develop an individualized plan going forward to help that individual go through the therapy. The way I sort of tell the patient is that this is sort of a honeymoon. We're trying to get to know you as much as you're trying to get to know us. So as we learn about the patient, we sort of readapt or tweak that person's program going forward. So as many patients as we have here is as many programs we have here. Not everyone is the same. So everyone has a brand new schedule every day based upon the types of therapies they need. We don't want to, if a person's memory is stellar, why do extensive cognitive therapy when it may not be needed, okay? Then the activity level is now then engaging those persons in therapies after the assessments are done. So they really start getting in the environment. Usually at this level, we're still in-house. And then later on, the participation level, we try to get the folks out in the community. So a lot of our folks who are able to do so, we'll take them out to the local supermarket. We'll take them out to local attractions to help them engage in that process. And in some cases, we'll even do mock sort of job situations or settings. We're not necessarily going the Voc route, but we're trying to put them into a restaurant setting, and maybe we have a local hardware store on Broadway that we have folks go to and just try things out and see if they can follow orders and follow a sequence, and we get into that level. So again, going back to the evaluations briefly, me being the only doctoral level neuropsychologist here, I do the neuropsych evals, of course. But we want to, and the tests are primarily paper and pencil, but we're assessing a lot of things in the neuropsych eval. I'm looking at sensory motor, I'm looking at attention, concentration, memory, IQ, visual spatial skills, language, executive functions, and also, again, personality and mood. And I'll discuss why we look at that last one very carefully going forward. But just a moment here, I just want to mention about when we talk about memory and attention concentration. When I do an interview with any patient that they come in here, I'll usually ask them, what are some of the cognitive symptoms that you're experiencing since your injury? And about 95% of the time, they're saying memory impairment. There's a memory problem. And I do the testing, and the memory may not be stellar, but it's definitely not their major weakness. And a lot of the times, it's not so much the memory, but it's the attention and concentration. So I'll start getting some input from therapists, like, I can only get Johnny to pay attention for about 10 minutes in that session, then he's off somewhere else, But he's remembering the names of all his orderly staff, he's remembering the names of all his therapists, but he just cannot focus long enough. So we realize it's not necessarily the memory that's the problem, it's the focus and attention. So again, if the folks here in the audience, if you're not paying attention to me, you're not going to remember what I'm saying. It's that simple. So again, so in that case, we sort of back off some of the memory stuff, and we want to make sure that we can get attention back and running. So when I go into the individual domains, I'll talk a little bit more about what we do with attention. And what we do here as well is we focus on individual and group settings. So we're at about a 70-30 split. 70% individual sessions, about 30% group therapies for the patients. Okay. And again, some of our groups include mobility training, cognitive skills training to look at daily planner use, note-taking, errand lists, and so on, really helping the folks problem solve. And what I'll also discuss a little bit about the supervision levels here at TLC and how we look at each patient differently. Okay. We want to try to provide the basis for ongoing assessment. Again, through some of the metrics we have now and the increase in technology, we can start assessing patients going further out during their stay here. So like our PTs, they do a Berg test, which is a balance test. So when they come in, it's BERG, Berg. When they first come in, we get an assessment, and after a few weeks, we could reassess them and see if their score is improving. We do the same thing with the cognitive scores, same thing with OT and the hand therapy. We could look at fine motor skills and gross motor skills. So we are assessing it ongoing. We want to look at the improvement, not just see it for ourselves. We want to get an actual measurement of it. And a lot of times it is trial and error. Even though our assessments tell us certain things about the patient and there's a consensus amongst the disciplines, we do find out that certain environments may not be as beneficial than others. If we'll find out by a patient that cognitively he's doing quite well, physically he's okay, maybe needs some work, but when we put him in a busy gym, he breaks down, can't concentrate, can't focus, and things go down the toilet for him, so to speak. Then we start modifying the environment. So, well, let's try doing some of these therapies in a more quiet, less stimulating environment. We'll then maybe see some progress and some improvement. So it's really it's the therapist, again, still learning more about the patient and what works for him or her or not. So really, that really sort of sums up the interdisciplinary team. We're not 4 or 5 disciplines here at TLC that work independently. We all work together to find out the common cause and what's the best for that patient going forward. So we all round every week, Tuesday mornings, we all discuss each case, we all share ideas on how to best approach that case. Sometimes the PTs and the psych counselors will co-treat because there is a situation where the it's maybe too high stim for them in the gym, so the counselor will be there to sort of help them maybe reduce anxiety and to really go forward in terms of getting their physical therapies done. So these are some pictures here. This is one of our past OTs, and again, just helping an individual in the ADL kitchen. Again, now in the participation level, we want to look at the real life activities. And again, going forward, we do neuro rehab, but we also do community reentry. Our goal, hopefully, is to get the majority of those patients back out home to doing some sort of productive activity, whether it's going back to work, whether it's being able to stay home alone for a period of time, whether it's to help in their spouse with childcare, whether it's even to just do basic things. Maybe sometimes if they could improve their ability to transfer from the wheelchair to the commode, if that's going to be less stress for the caregiver, that's a goal. It may not sound like a tremendous goal sometimes, but it's a goal. We work with the patient's limitations. So that's important. Okay, and then of course we're very fortunate here in Galveston. It's a small enough community where we have the local grocery store that us very well here, so we have an account with them. We bring our folks out there. The OTs will develop a shopping list and a budget. We'll work with the patient to develop a budget. They could budget on a certain amount of toiletries and other things they need to buy during the week, things that we don't typically supply. They have an OT account, and they can go out and do some shopping. Also, again, we have a bus system here, so we'll actually help the folks sort of learn some basic routes here in Galveston. In some cases, I remember this case specifically, the OT put him on the bus by himself. He paid his fare, and she then was in her car behind the bus and just made sure he got off at the correct stop. So really just to make sure that they can start to learn some of these basic routes. Okay. So when a patient admits to TLC, we have supervision levels. So usually they come in at a high structure level, which we'll usually call a level 3. That person is going to be a one-to-one. So the orderly staff who here at TLC, we call them TAs, for therapy assistants. We don't like the word orderly. So we call them TAs, and that TA is assigned to that patient to make sure there's no issues going on when they're either if there's direct care needed or when they're going from one module or one therapy to another across campus. And that person, of course, requires max assistance to a degree. So we want to make sure they're safe. That's the primary goal. When we start to realize that the person the cognition is coming back, they may be emerging from post-traumatic amnesia, we start to feel a little more, that the honeymoon period is sort of coming to an end. We feel a little more safe about them doing some things on their own. Sometimes they get a little grouchy and they're like, I don't want this person following me around anywhere anymore, which is true. But as long as we feel they're safe, then we'll back the TA off. And we'll do sort of a line of sight where the TA is there but sort of hiding in the shadows, just making sure the person gets their correct therapy and there's no issues. And if there is a situation where we feel the person maybe not so strong yet with their legs, but they are ambulatory, sometimes we'll put a bicycle helmet on them. We understand falls can happen. We want to make sure they're safe. And then the real life environments, now this is a supervision level 1. So that patient is really free to roam around campus as they feel fit. We, of course, have cautions in place. If the person doesn't show up after a few minutes to a module, we all pan out and make sure that the person's close by. Again, but we have folks spread out through the facility all the time, so we have very few elopements. It does happen, but Galveston PD is very, very well aware of what we do and who we are, so they never they never get upset when we give them a call. But again, it happens very, very rarely. A few years ago, we had a patient who he was a young guy. He was about 20, 21 years old. He had a walker. He had a pretty nasty motor vehicle accident. Not fully oriented yet, still a little confused, but he was able to get himself going and moving. He was very slow. He was in a walker. So he left the campus, and right away a TA and one of our psych therapists right behind him. And by the time I was alerted, they were already about 2 blocks away, which I was thinking, like, why'd they let him go 2 blocks away? But regardless. So I get in my car, and I drive down, I find him, and he's still with his walker, but now he's going towards Broadway. It's a major, road here in Galveston. I'm getting nervous now because he's getting way too close to Broadway. So I stop in my car, and the TA and the counselor, they're not sure how to exactly stop him. So I just gently go over to him and say, hello, how are you? And he's still a little upset. He's sort of going away. And I just hold him by the bottom of under his arm, and I just take the walker away. And I'm standing there with him, and he's looking at me, and he's like, you got me, doc. And I helped him down to the curb. And by that point, one of the case managers had called the cops. So the cops pulled up. The kid, he did have a troubled past. So when he saw the cop car, he thought it was all over. He was like, oh, my God. I'm like, you're going to come back to us, but because of your safety, we came to look for you, and we did call the cops, but you're not going to be arrested. You're coming back. So he was very relieved to hear that. But in some of those cases, you just have to use common sense. How do I diffuse this situation quickly without, of course, having the patient get hurt and staff not get hurt? He was getting pretty close to Broadway, so I wanted to diffuse it very quickly. So it was one of those cases where he was supervision level 1. We trust him amongst on campus, but he got in his head, I'm done with this place, I'm bored, I want to go home, I'm going to call my brother to pick me up, and he thought his brother was going to wait for him blocks away, but that was not the case. So it is what it is. But again, we try to foster independence. We're not keeping the folks at supervision level 3. We want them to gain that independence and trust. We want them to, sometimes, not that we want our patients to fall, but sometimes if you do trip or fall, or you have to learn how to get yourself back up again, sort of the sense. So what we're thinking as therapists is how can we modify the task given the patient's deficits? What is their learning style? And sometimes we get a lot of great feedback from families. So for me, as a neuropsychologist, Betty knows this, for me, like, the most important thing is the clinical interview. I get so much information from the clinical interview before I even start doing the testing. And if I see a family member on campus, I am pulling them in because I want to get their feedback as well. A lot of our patients are not the best historians. We're not going to get the best information from them. If I see a family member, I am pulling him in right away, okay? How do they respond to the intervention? Again, we'll have folks that are kicking and screaming. We have some folks that are just fine and dandy the way it is, and we want to make sure that we get them in that right groove so we can get them the most benefit. And how is the therapist? How can we change our style? So it's a high stim environment, low stim environment. We've had times when a patient just doesn't like a particular therapist and no particular reason. So sometimes we'll do, musical therapists. We'll switch them up a little bit, see how that works. And sometimes it works, and the person just goes on, and they just may not have a liking for someone. But usually it's more of an environment change, not necessarily a therapist change. Okay. And these are other things that we have to consider. Brain injury, I actually co-wrote a paper in 2014 looking at fatigue in TBI. It's rampant, and a lot of our folks will come to us and they just peter out really quickly. And it may not be because of pain, it may not be because their legs are not working or strong as they used to. They just get tired much more quickly. Their muscles get fatigued. There is a chemical change that's going on. It is metabolic. So fatigue is huge. And in TLC, we pride ourselves that we're getting these folks 5 to 6 hours a day of therapy. That's a lot of therapy if you're only about 1, 2, 3 months after an injury. It's a lot. But again, of course, we try not to, but we will allow breaks at times if a person really just can't go. And we try to do it strategically. We notice a lot of times the patients have pretty good energy in the morning. By about 1 or 2 o'clock, they start to peter out. So we try to modify the schedule as best we can. Motivation is a huge deal. And this is a lot where the psych comes in, which I'll talk about a little bit more. Sometimes they may just need that counselor to give them a pep talk about some, it could be pre-morbid history of depression or current depression or symptoms after their injury. The environment, medications. A lot of the medications they could be on, whether it's a anti-seizure med, that's going to make someone tired. That's going to make someone's memory not be optimal. So we have to consider that as well. And that's why we have Dr. Falco in our rounds with us to explain exactly what meds the patient's on and what are some of the effects. Because the therapist may say, oh, Mr. So-and-so doesn't want to do this. He doesn't want to do this. Well, I put him on this new medication. It's going to probably make him a little tired. Let's see how we can work around that best. Sometimes we'll shorten this therapy session. Instead of 50 minutes, maybe we'll try 30, 35 minutes to see what best suits the patient so we can get the max yield. Okay, and again, I go back to the personality and psychiatry. I'll get to that shortly. And of course, this is without saying, motor sensory, communication problems, cognitive and psychological. You know, I think we're experts at working with patients who are aphasic, but it's challenging. It's hard when a person cannot express themselves to you, cannot understand what you're saying, and you're trying your best to give them proper instructions on how to best transfer, how to best do hand therapy. It's hard. So there is a lot. You know, these therapists can get burnt out very quickly. You're doing very repetitive motions, and especially when you're trying to communicate with someone who may not be able to really understand you. Okay, so well, you know, of course you look at Webster's dictionary, but again, who really looks at Webster's dictionary anymore? You just Google something these days. So clearly their scope or their definition of cognition is much more simplistic than what we know in the field as a neuropsychologist or rehabilitation therapist. We know there's a lot of things associated with it. So I'm not going to go through everything here, but again, as you can imagine, each part of the brain has sort of different sets of functions. So the frontal lobe has a lot more with sort of cognitive type skills, also personality, emotional issues. The parietal lobe has a lot to do with more sensory input, integration, visual spatial skills. Temporal lobe has a lot to do with memory, language, auditory, emotion as well. And the occipital lobe is pretty easy. That's our vision center. Okay, you know, somehow the plans were the eyes are here, but the vision center is going to be way on the other side of the back of the head. Okay, and we will get folks that have some significant visual problems, but it's not that common that we'll see folks they'll have TBIs and/or strokes in this area. What does happen, we actually have a woman here right now who did fall back and she hit the back of her head. Her skull was fractured back here, but there was no cortical damage back here. Most of the damage was done to the front part of the head. Okay, it was a contra coup injury. So the shock here caused this part of the brain to hit the skull, and the injury was actually more here than it was back here. The skull did its job. The skull prevented the tissue back here to get hurt, but the reverberation affected the front part of the head. Okay? So in a moment, I'm going to talk about an individual that had a lot of these more frontal type problems. Okay? And again, I think if some of you have seen me speak before, you know who that is. Not this guy. So first, attention concentration. So I'm going to go through some of the cognitive domains. So I know it's probably hard to determine here what's going on, but if you notice, the left side of this guy's face, is not shaven. The right side of his face is shaven. Okay, and this is not a patient of ours. This is something I found on the internet. It's just a picture, but this person is suffering from neglect syndrome. So in the majority of cases, if individuals have right hemisphere damage, they have a problem with attending to the left side of space. It could be visual, it could be tactile, it could be auditory, okay? And when I first came here in 2005, a lot of our TAs were like, well, you know, Dr. Z, Mr. So-and-so, he's always bumping into the door frame on the left side. He's got bumps and bruises all over his knees and elbows. I think he's got a field cut. He can't see on the left, and I think his ear, something must have happened because he can't hear me on that side. And find out that it wasn't a sensory motor issue. It was neglect. Usually the person's vision and tactile abilities are fine. So what I'll do sometimes is I'll ask the patient, have them put their hands out, and I'll have them close their eyes. And I'll tell them, you know, tell me which hand you feel me touching. So if I touch the right hand, they'll say right. Touch the left hand, they say left. I touch both hands, they'll say right. Okay, they're actually extinguishing that sensory input on that left side because neglect is like a tug of war. So imagine the right side of your brain or the right side is like a tug of war with your left. It's basically saying, no, I want all the attention over here. So it's making it so much harder for that right brain to get that attention to go left. Okay, so the folks may have a tactile issue where, again, when I touch both hands, same thing with hearing. I can do the same thing. I'll do this to behind their head. I'll make a little noise. They hear it on the right side. They hear it on the left side. I do both. The right side pulls that attention over. They always say right. They don't say left and right. Same thing with the vision. So I'm trying to discern what is a visual field cut, what may be a sensory loss in that ear, what could be maybe a sensory loss due to some brain injury, or what is neglect. Okay. So in this gentleman's situation, we said, okay, well, we've had situations. It's not an actual one of our patients. Did you shave? Yeah, I shaved. Okay, well, it seems like you missed a little bit on that side. Oh, yeah, maybe I missed a few spots, but they just didn't shave this whole side of the we see the same thing with clothes. They'll come into a session, they'll have this side of their shirt on, and the arm is out of the sleeve and everything on the left side. You put your shirt on, oh yeah, everything's on, it's good. We've had cases where we'll literally show that person their hand. Whose hand is this? I don't know whose hand that is. So these kind of things happen. So it could be the severity of the neglect could be pretty severe. It could be very mild, what I would call like an inattention. They may not catch things on the left that quickly, but usually they can get oriented. In some cases, it's almost as if the world is cut in half. They just don't attend to that side. So I'm going to show you a little bit in just a second. Well, it can be worked on, but not fully. Not in my experience that it can be treated, so to say. But let me go into a little bit. So in a neglect syndrome, there's this failure to report, respond, or orient towards a stimuli in the contralesional space. And by that means, so if the lesion's on this side, contra to that. So in all cases of neglect that I've worked with, the injury is on the right side of the brain. Okay, and I've heard cases of people say left side. I've never seen it. I would like to see it if it exists, but I haven't seen it. Sometimes the patient will say, well, I can see, but I can't see. I can hear, but I really can't hear. Feel, but can't feel. It's not a sensory motor issue. It's more of an intentional issue. Sensory motor deficits must be ruled out, so that's why I do the sensory motor evaluation. They're usually unaware of their attentional deficits, so in the most severe cases, there's anosognosia, where there's nothing wrong with me. But sir, your left arm doesn't work. It's actually, you're very close to putting your fingers in the spokes of the wheelchair. You may hurt yourself. No, my left arm is just fine. Everything's fine, no problems. You sure? Yeah, it's great. Everything's good. I could lift up anything with my left hand right now if I wanted to. Okay. In some cases, in the anosdysphoria, it's where there's this sort of, it's not a lack of attention to it, but there's a dismissal of that side. Oh yeah, that left hand, it does that sometimes. It goes by the wheelchair. I just, swing it back up, But there's a dismissal to it, okay? But they're acknowledging it, but they're not paying much attention to it. And in other cases, other parts of the body, I won't get into that right now, but it occurs in a large number of folks with right-sided strokes, about 40 to 70%. To answer your question, sir, about treatment, the functional outcome after neglect is not so great. It is a very difficult thing to overcome, okay, for these patients, and it persists in about a third of patients. So here's an example. So we have one of our rec therapists years ago. He would work with patients on doing model planes. So one day, this is early on, I wanted to sort of show some of our TAs what is neglect. Why is this something that's real, and how, to give them a feel. So I asked the patient to draw the picture of that plane as best they could. So that's the picture. Now, this person had neglect. So as you can clearly see, well, probably you could draw a plane better than I can. But the right side is pretty well formed, right? You have the propellers, you have the landing gear, it's colored yellow on that side, and so on. But look what happens to that left. Just totally breaks away. Okay, so the sort of the gestalt and everything of that plane just falls apart. He acknowledged some aspect of it, but what's happening probably here is it's probably a problem in visual spatial memory. The person's not scanning appropriately. Their brain keeps wanting to go to the right. They scan the right, and they sort of go a little left, and they sort of go back again. They're not really giving that left a good chance to get absorbed in the visual system. So what I did was like, well, let me see what happens. Let me turn the plane 180 degrees and ask the patient to draw it again. So here, now you can see what was once very poorly drawn now has more detail to it. You can see the yellow on the right side, the tail is much more formed, better, and so on. And as you can see, as you go more to the left, it starts to fall apart again, okay? So a lot of our cases are not always neglect. Okay, well, that's a good thing. Right now, I think we have one person with neglect, but on average, over the course of a year, we'll probably have about a good maybe 6 to 7 folks with some pretty severe neglect. But usually what happens to a lot of our folks is the impaired sustained attention or vigilance, decreased divided attention. They get very easily distracted. It's so hard for them to stay focused. Again, we discussed neglect, and a lot of it can be information overload. So we know that if a person is coming with really poor attention or concentration, we want to now do an environment change. We want to bring them more in a low stim environment, maybe not have as much distractions, okay? So really this sort of helps us guide our therapies. What I do in the neuropsych department, we do attention process training. It's an auditory task, and it's sort of geared to slowly help build up attention. It's a very, very, I hate to say it, it's a very boring auditory task where the person just presses a buzzer when they hear a certain stimuli over the CD. And of course, over time, it gets more complex, and they have to respond more quickly. So it does help slowly, progressively get processing speed and attention better and better. So That's something we use here. Of course, there's some other things about time pressure management, but really the goal is to develop the strategies, not restore the attentional dysfunction. We're not trying to remediate the broken system necessarily. We understand it's broken. We want to try to improve it as best as we can, but we understand we're not going to fix it exactly. So let's develop some compensatory strategies to help it as much as possible. And again, where the medical director falls in with pharmacological interventions, so a lot of times methylphenidate, other types of psychostimulants, similar type medications we would give the kid with ADHD, does work very well with folks with TBI. Okay. When it does come to, now with neglect, we do focus a little bit more on remediation. We try to limit distracting stimuli on the ipsilateral side. So basically, if you think about it, if I now distract or limit information on the good side, where the attention is good, then that can help them focus more on the left. I want to try to increase stimulation on that left side. You want to try to refocus the patient to the contralateral space. Sometimes it's very simple strategies as when you are looking or scanning left, get that chin as close as you can to that shoulder. I mean, some basic stuff. Me personally, I like to really inform folks, this doesn't sound very nice, but to install some level of self-doubt. Let that patient realize that when you enter a new environment, because of your neglect, there's a good chance you're going to miss out on something. Because I'm thinking about their safety. I've had patients, one story, a woman, she was a smoker, she had a right hemisphere damage, she had a left neglect. One day on a weekend pass, she got out of the car, her husband helped her get out of the car on the passenger side. He said, please just stay here, I'm going to go on the other side, get some things, I'm going to come right back. Well, she was smoking a cigarette, she drops the cigarette, the wind started to roll the cigarette towards the left, and she was going to try to stamp it out. She was not realizing the extent of which she was not attending very well to the left, and she fell over and busted her leg. So here she was trying to improve herself in brain injury rehab, but she ended up actually, slowing that down by several weeks. Okay, so really sometimes I'll just have the patient develop this level of self-doubt. Okay, I'm going to an environment, what they're going to think about, because a lot of these folks with neglect are also very impulsive. So you're really fighting two things at one time. Okay. So this is something we do here at the PRISM Adaptation board. So what I do is we use these PRISM goggles. The folks do not wear this throughout the entire day, but essentially what they do is just for the few minutes when they're in the session, and we put their so imagine the person sitting on that table. They have the goggles on, and the goggles are sort of shift the entire visual world about 10 degrees over to the right side, so they can pick up that information. They put their chin on the board, and you see the two dots there. Their job is simply to just reach out and touch the dots in a V formation, okay, and while they're wearing the goggles. Before I put the goggles on, I ask them to touch the center of the two dots. And the extent of which their pointing is more on the right side gives me an indication of how extensive the neglect is. After a trial with the goggles, you'll find out that they revert more to the left. So it's really just an exercise, because what happens is that the chin guard prevents them from seeing where their hand is. So as they're reaching out, all of a sudden the hand comes out at a certain point. They have to now guide their hand better on that side. So after a number of trials, then we take the goggles off and we notice that they do shift a little bit better to the left side. And again, we do a lot of repetition here, but it's not a treatment or cure. Okay, so what we find is that sometimes the effects can last a few hours, if not a few days, or maybe even weeks, which is beneficial because now the folks can do more in their physical and occupational therapies. So we'll just continue to maintain the PRISM adaptation protocol while they're here. So this is a gentleman who was actually a patient here years ago. He's a former military, and he has some severe neglect after his injury. So it just gives you an indication of the goggles. Again, he's not wearing these throughout the day. In this case, the clinician just sort of blocked his view with an envelope or a file here, and his job was to point out to these stimuli out here. And after a while, they take the goggles off, and you could gauge the level of improvement. Okay, the memory, and this is always fitting because we're in Texas. So the guy says here, remember that place in Texas, which we know is the Alamo. So memory, like I said, is the biggest complaint, or the most frequent complaint I get from our patients. And there's several ways you can look at memory. You can have impaired short-term working memory versus the long-term store. In a lot of our cases, the folks with that post-traumatic amnesia. You can have individuals have worse verbal versus nonverbal memory. Now, verbal memory is usually going to be on the left dominant, the language side. And usually you'll see more nonverbal memory impairment with more right hemisphere type dysfunction. Okay, it's not always that clear cut, but again, usually we'll see some difference. You can have encoding deficits, retention deficits, retrieval deficits. So encoding, think of someone who may not have a TBI but may have some sort of Alzheimer's disease or neurodegenerative disorder. Those folks are having more of an encoding deficit. They just can't get the information in. That's the problem, okay? So if I have someone who had a stroke or injury to an area of the brain called the hippocampus, then I would see more encoding deficits. The hippocampus is a part of the brain in the temporal lobe which helps us lay down those memories. It's very important. It's crucial to memory. If you have an impaired hippocampus, you're going to probably be amnestic. You're not going to remember much of anything. And that's more of an encoding problem. In a retrieval problem, imagine it this way, where I always use this analogy. Imagine in your brain you have all these file cabinets, and in the file cabinets you have all the information you need, right? So in an encoding issue, the information is not getting in the file cabinets. In a retrieval problem, the information is there, but you're not effectively getting to the files, okay? So in a person with a hippocampal deficit, I would expect an encoding problem. In a person with a frontal damage, I'm going to expect more of a retrieval problem. Information is there. They're learning, but they're doing it very inefficiently, right? So it's like they're not doing it in a very organized fashion. So because of the inefficiency, the information doesn't come out well. It doesn't come out in a certain way, and it seems like they're much more forgetful than they really should be. And then also you have procedural and declarative memory. Procedural, sort of like learning a bicycle. Once you learn, it's a motor procedure. You usually will not forget it, okay? What we do here in rehab, some of the basic things that we all do really to help us learn on a day-to-day basis: checklists, other organizational devices, which is essentially these days your smartphones, because they do everything. Perspective memory devices, environmental modifications. You know, sometimes, like I mentioned earlier, with the individual learning to what do they put on first, the socks or their shoes, the OT will have that little sign on the board. External, internal aids, but again, like I said, practice makes perfect. Rehearsal, rehearsal, and then some more rehearsal. Some basic things that we do, the folks here get a memory notebook that every day that they have their schedules and some other pertinent information in there. As that person has, they improve in their functional abilities, will then use their smartphones to put their schedules in. They'll do it themselves versus us giving them a schedule at the beginning of each day. So they become more responsible to maintain their own schedule. Visual spatial deficits, I'm not going to focus on this one too much, where we have the ugly duckling looking in the pond, and they're seeing maybe what they want to see, but it's not necessarily the case. Okay, so the visual spatial deficit is not necessarily due to poor visual acuity, which we do have a lot of patients who do have low vision or a field cut after an injury, not neglect. So a field cut is sort of like a partial blindness. Because of where the trajectory of the optic radiations are damaged, the person may have just maybe a little quadrant of their vision out. They may have an entire side of their vision out, or have a huge swath of their vision out, but maybe like a macular sparing where they really are just getting sort of a pinhole amount of vision coming in. But in these cases, this is more about where things are in the world. How does our brain perceive the where? Okay, so our brain sort of looks at it very sort of binary. We have a what pathway and a where pathway. The what pathway sort of takes objects, things that we see every day, it breaks it down to its components, and then we have a way that it tags it verbally. What is that? What is this item? What does it do? So we know that this is a cup, okay? The where is now, when I reach for that cup, am I not overshooting? Am I making sure that I'm putting just enough effort, motor effort that I'm exerting to reach the cup? Am I pushing too much on my arm? I'll spill it over. If I don't put enough, it'll take me forever to reach the cup. It'll be like slow motion. So that part of the brain, the visual spatial deficits, is what's affecting a lot of these folks in terms of visual scanning, figuring where things are in space, how they react to it. And sometimes they'll even see the world a little bit more in a piecemeal fashion. They get the sort of little bits here and there. They're not getting the full gestalt. So in these cases, this is much more challenging, and it's much more rare as well that we have these real more significant visual spatial deficits. But usually it will form more we see it more in the visual scanning or visual construction aspect. Okay. Again, these are just some visual, I threw some visual deficits under the visual spatial when we have visual loss or change. A double vision is diplopia. The person is seeing two of everything pretty much. That usually gets better. We could do some things like eye patching. If you obscure one eye, usually their double vision goes away, or temporarily, of course. And then we want to help, again, we'll do some basic things about campus mobility, simple maps around the campus, but also we're trying to help them use their memory to help improve their visual spatial deficits. Okay, and then coming a little bit closer to a close here, communication. And I mentioned a few times today about aphasia. Aphasia is very, very limiting for a lot of our folks, and Again, usually as soon as I read a screening assessment, I see, left hemisphere damage, left middle cerebral artery damage. I pretty much can guarantee that person can have some level of a language impairment. But we have a case here right now. She's actually discharging today. Phenomenal. She came to us back in like November. Left hemisphere stroke, right hemiparesis, severe global aphasia, really could not comprehend or express very well. By the time she's leaving today, she's been in an apartment, functioning semi-independently, doing most of her ADLs by herself, able to, comprehension is very good, but the expression is still sort of telegraphic. She can get the words out. You can understand what she's trying to tell you, but she can express her basic needs, but she's not going to be the conversationalist. But still, I mean, the level of improvement she's made just in about 4 or 5 months has been awesome. Uh-huh. Uh-huh. So not to communicate necessarily, but in the early stages, we were using the iPad, certain apps. Speech paths are much more fluent, and they can probably give you a much better description of what they're exactly using. But to help them develop and sort of, sometimes it'll just be a picture board, bathroom, toilet, or eating, food, whatever it is. And we just sort of start the basic building blocks, and we just build up from there, yeah. But we do have cases where the person really, maybe it's a motor speech issue, and they cannot vocalize, so they will type in, they press a button, and then of course the computer speaks for them. But that doesn't happen as often. So in addition to the expressive or receptive aphasia, we also have folks that have oral apraxia or apraxia of speech. Usually it happens in combination with aphasia. So it's not so much that their brain is not interpreting or able to express the language, but also because there's a disconnect between their ability to move the motor aspects of their mouth. So they're not making the proper motor movement, so it's hard for them to get words out. It's usually see a lot when it comes to repetition exercises. And then also gestural communication. That can also be affected after an aphasia. So doing something like this to someone or going like this. I mean, these are things we all know. Person may not be able to do those things or understand what these mean. So really it affects all aspects of language, not just spoken language. So something to keep in mind. So like I was addressing with Betty, we work with our speech therapists, computer-aided devices. The iPad has been an unbelievable tool. If some of you remember from about 10, 15 years ago, we had the Dynavox, these big clunkers. And the patients sort of have this big strap around their neck, and the poor guys with the cane and so on, they have these things that are sort of weighing them down. It is true, and these things were heavy. They were huge and expensive too. Now the iPad for a couple $100, and it's lightweight, and they just throw them in their backpacks, and it's not a big deal. So it's working. It's much, much, much better for these folks. So again, our speech paths are working with them, for those folks with oral apraxia on mass practice, oral motor exercises. Of course, swallowing is a huge issue. We have a lot of folks with dysphagia, so we get them on a protocol. We want to wean them off the PEG tube so they can actually go back and swallow. So our speech paths are working with them in the cafeteria to do that. And also, of course, the typical modifications, notebooks, and so on, other compensatory strategies that we discussed earlier. So getting a little closer to the end here, looking at executive dysfunction or executive functions. And this is the domain that I get most concerned for with a patient after their injury. Usually, you could sort of see it right away. These folks are typically ambulatory. They don't have much in terms of motor dysfunction. They won't complain of really sensory dysfunction. Their vision, everything else looks pretty good on the surface. These are the folks that if you see outside, you didn't know them, you would think that's just the average man or woman who's walking up and down the street until you engage them. And then things start to get a little interesting, okay? All right? And it's hard because their awareness is not there, and they are sort of running on this path of least resistance. There's a lot of roadblocks that we experience going through life, whether it's we're law-abiding citizens. We know, well, I can't do this because I can get in trouble, or maybe that's not socially appropriate to say to a group of women, so I'm not going to, certain things that we know how to block ourselves from doing. Well, a person who may have an executive dysfunction, those stop signs just got thrown out the window, and they're just going to say or do whatever it is they feel is okay in their world, okay? And then when you try to tell them they're wrong, they sort of look back and say, no, you're wrong. So with the executive dysfunction, here we're going to see a lot of the problems with planning deficits, sequencing deficits, time management. These are the folks that were like, uh-oh, it's 10 minutes after the hour, where are they? They're here. They're just like, oh, I thought breakfast was at this time. I'm sorry, I was just watching my TV show here or whatever. And you're like, no, you got to get your butt up. Self-monitoring, that's a huge one, and that's the one that's of greatest concern to us, because we want these folks to sometimes be able to go home and be responsible, take their own medications. But if they're not monitoring that well enough, they're not cognizant, oh yeah, it's this time of the day I have to take, no, then that's where a lot of issues pop up. Impulsivity is huge. So we really want to make sure we monitor that, because there's a huge safety concern with that. Functional problem solving, decreased initiation, these are some other issues, especially with the person could be apathetic. That's another concern we have. I'll talk more about that in a second. Planning deficits, again, really very, very huge. So really we try to help them with structure with planning sheets. We'll have them have a shopping list ready to go, and the OTs will work them very diligently to make sure that their list is what they need. Sometimes when we allow them to do the list the first time by themselves, all of a sudden, it goes to like, chocolate bars and this and that, and they're buying things that they don't need, but because that's what they want, and because there's no stop sign or for them to not realize that this is not what you need right now, they'll start putting on what they want. The desire kicks in first, okay? Sequencing deficits, so they'll need some detailed checklists. Time management is the hugest part of usually of executive dysfunction. So again, with our smartphones these days, we can set up their calendars with alarms and everything so they could better organize themselves. And again, going back to self-monitoring, self-awareness. Like I mentioned earlier, sometimes telling some of those neglect patients a little bit of self-doubt. Same thing you do that behaviorally with an executive dysfunction patient to sort of help them understand that here's a situation, you're going to walk into a room with a bunch of people, what would be an inappropriate thing to say? And they'll give you an answer, and you can work with them and try to field out what their answer was, how accurate it was, and work with them on it. Then, of course, in community reentry, we're going out to the real world. So we're going to a real supermarket, we're going to a real museum, a real library. Library is the best, because right away you know a person's going to walk in there and just sort of use their loud voice, and you have to try to tell them to be quiet. And then see how much it really kicks in, okay? But what's the biggest issue with executive dysfunction patients is they're not getting the consequence. And that's the biggest problem with executive dysfunction. They could usually tell you what's right and wrong. And you're like, oh, this is great, he knows exactly. And then you go out in the environment and they just totally down the toilet. It's the consequence. If you're not feeling that anxiety, if you're not feeling that shame by doing something inappropriate in the environment, then you may just do it anyway. That's really what the person's mind is like. They're not experiencing that consequence. So we try to develop, and we'll do behavioral modification. We'll develop probably the most benign type you can do, because we're not looking to harm or threaten or punish the patient, but we want to set up something that they desire, whether it's a type of treat or a TV show or something. See if there's some way we can sort of use that as a way to help them engage in appropriate behavior, okay? So there's a lot of behavioral modification going on here. So we sort of use the problem-solving, modified problem-solving style from the Ben-Yishay program, where we identify the problem, try to generate multiple solutions. We'll trial and error. We'll try each of those solutions as best as possible, then look at what happens, what worked and what didn't work, and we try to sort of hone in and see what is the best approach for that particular patient. If there's a decreased initiation, we use alarms, environmental cues. What's very much associated with frontal dysfunction can be apathy. It's usually more of a medial type dysfunction of the frontal lobe, where the person may seem depressed, but they're not depressed. It's just a lack of motivation. You can ask that person, you feel depressed? No, I feel fine. I mean, this happened today, I'm happy about that. I called my wife, she told me something cool about what happened to kids. I'm excited. Okay, well, let's go do something. Yeah, sure. All right, let's get off the couch, let's go. Yeah, okay, no problem. And they're still sitting there. So it's it's like that oomph is gone, that motivation, that drive has sort of escaped them. But it doesn't mean they're depressed. So that's another thing the neuropsychologist is trying to help differentiate that as well with some of our folks. So this gentleman, and again, if you see me present, you probably know who this guy is by now. Anyone not know who he is? Oh, good. So you guys definitely have seen him before. So this gentleman, long time ago, he worked in the railroad, and he had an injury where that iron basically went through his face. Okay, it sort of hit him right here, went through the back of his face, and popped out the side up top of his head like a rocket. Okay, he was working out on the railroad. This is going back 150 plus years ago, and he's tapping down the gunpowder because they're blasting the sides of the mountain. He hits a rock with the iron pole that ignites the gunpowder, and it like a rocket right through the top of his head. Okay, and you can see, when I first showed this picture, people thought he was like harpooning a whale. Like he must have had some injury from being out in the sea or something. But no, That's the actual iron pole, and you can see where his eye is damaged. So it sort of went through here and came out the top of his head over there. And that's the actual computer sort of regeneration of what happened to him. And what part of the brain was most affected? The frontal lobe, okay? So here's a quote from his doctor from, again, that time. So he's fitful, irreverent, indulging at times in the grossest profanity, which was not previously his custom, capricious and vacillating, devising many plans of future operation which are no sooner arranged than they are abandoned. That is like the perfect 19th century definition of executive dysfunction, okay? That's exactly what we see in a lot of our patients. The consequences are thrown out the window. They're not, this is a mild-mannered, probably average Joe kind of guy before his injury, and now he's cussing up a storm, and this is Victorian times. He doesn't care what's going on. Can't make up his mind. He'll start doing one thing and he'll stop that and start the next before he finishes the previous one. That's exactly what we see a lot of our folks with executive dysfunction. And lastly, we're going to go a little bit over the psychological sequelae, because a lot of our folks, of course, they do realize that acquired brain injury, while it's no longer a fatal condition, our medical technology and science has been able to bring folks that 100 years ago there no doubt would not have survived. But now we can have folks in the thousands survive these horrible injuries, but it's not curable. Again, you ask anyone who has an acquired or traumatic brain injury, they will tell you, I have an acquired or traumatic brain injury. You don't just get cured from it. You will always have it. You can get better from it, but you will always be an individual who has had a TBI. And there is a chronic disease model associated with it. We do know that a person who is healthy before their injury, after their TBI, can still have a medical or metabolic cascade, things that are now changed because of a growth hormone deficiency, a pituitary gland dysfunction, where now a lot of other things will happen. We have some folks that will develop HO or heterotrophic ossification in their joints. It's just basically bone growth that would not grow there before. But because now the changes in the hormones, bone growth starts to develop in the joints. It causes them a lot of pain and discomfort because they can't move around as much. So a lot of these things can happen, heart difficulties and so on. The patient must learn to cope, of course, with these injuries, and usually they'll fall into some categories of denial, or they sort of maybe just succumb to the fact, well, this is how my life is going to be, this is what it is, I'm not going to, why bother changing it? And of course, that's not what we promote. So that's why we have neuropsychology here at TLC and other post-acute facilities. We want to sort of help develop that. Myself and a few colleagues, about 3 years ago, we wrote a paper on psychiatric disease and post-acute traumatic brain injury. And the interesting part in here is I wanted to really introduce the main cores of what we see, depression, anxiety, but also I invited two individuals that really spoke a lot about substance abuse issues, as well as, so this gentleman, he spoke a lot about substance abuse issues in the article, and this gentleman, he spoke a lot about the caregiver burden and distress, which is really important to think about when you think about this dynamic. It's not just the individual that can succumb to psychiatric issues, it's the family members, it's the caregiver, because this is a chronic disease process. That person will always be brain injured. They may always have cognitive, psychological, or physical sequelae. So it's really a different dynamic than some of the other disease processes we may be familiar with out there. So again, and I do a whole separate talk on caregiver burden and stress. But again, not only is the individual maybe experiencing some of these, but imagine the caregiver having to now work with someone, a loved one, that is also suffering from impulsive behaviors, depression, apathy, aggression. How does that also impact the caregiver, okay? So again, these are a lot of issues that can happen, and there is a small percentage that may develop psychotic type behaviors. They may experience delusional thinking, auditory hallucinations, all those kind of things that can happen in some. Suicidality, of course, is much higher in folks with TBI and acquired brain injuries. So usually the first line of defense is psychotherapy, medication management. In some of the other cases, when it comes to impulsivity, we do behavioral modification as well. Okay. Again, assessment, psychotherapy. We have one licensed psych associate and one licensed professional counselor here at TLC. Of course, myself as a psychologist. So we do a lot of this psychotherapy and behavioral modification. But also what's important is family intervention and education. We want to make sure that the families are aware of why your loved one is now behaving this way, how are things that you can do as a sort of de facto professional to help them in the home. And we want to make sure there's resources and support after they do eventually discharge from a place like TLC. And that's it. I'm done. Am I on time? Oh, I'm a little early. Okay. So are there any questions? I know I sort of sped through some of that, but it is Friday, so. Any specific questions, thoughts, comments, concerns, anything? No? You guys just ready to leave?
Guys, Dr. Z, questions?
That's okay. Again, and maybe some folks saw this talk before. But again, before I leave, I just want to say, again, Eric, thank you so much for doing what you do. Thank you for coming here. I'm happy that TLC and your group have this connection and this association. And again, regardless if we won't be here much longer, but whether we're here next year this time or up the road, we'll always be welcoming and want you guys to join us and come to the facility to have your conference, okay? All right, bye everyone. Again,
Bye-bye.
with the business cards, you want to email me, call me, any questions, thoughts, concerns, please feel free to do so, okay? All right,
Thank you very much.
All right, have a nice weekend. Email me, I'll send it. Okay? All right, bye guys. Take care.
Thank you. Very good, folks. So what we're going to do right now is we're passing around the conference evaluation. And when you complete the conference evaluation, Dee will be at the door, and when you turn that in, she will give you the certificate. Do I have anyone here? You were just here for today. Anyone here just here for today? Great. So it should be 9 hours for the program, and then 1.5 hours for ethics.
The total is 9.
No, I think it's
Total is 10 and a half.
10 and a half. Yeah, but Linda, don't we do 9 and then 1.5 for ethics? Don't we do 9 hours for the program and then 1.5 for ethics? Separate them out, don't we? Yeah, correct. Dr. Larson left, but so that's the way we did it.